Is everybody seeing the skin soft tissue infection like starter page, the intro slide?
Yep. Yes.
Cool. All right. I did just hit the record button, so this will be recorded, and I'll try to stash this online. We had talked about doing like a Google site thing. I can make a YouTube account for the PHM POCUS um, email, and maybe that would be even easier to just have it sort of available on there and to do that with future meetings so that folks who can't tune in can at least watch after the fact. So thanks for coming. I almost just exited the meeting. That would have been bad. So I'm just going to talk about skin and soft tissue infection ultrasound in kids today. And this is, would apply to adults too, most of this stuff. Um, so our objectives are to examine skin and soft tissue with POCUS, so just kind of go over basic principles, and then recognize normal skin and soft tissue ultrasound, looking at infected tissue and evaluating for purulence, so whether or not that tissue is going to be amenable to either aspiration or an IND. And then we'll go through just a couple things that can look like skin and soft tissue infection or complications. So on exam, uh, this is the mnemonic I invented, double McDoppler, not previously published anywhere, so you heard it here first. So we're gonna scan in two planes, always orthogonal planes. So if I was looking on the neck, I would get a longitudinal scan like this with the probe marker towards the head, and then I want one perpendicular to that, so 90 degrees from there. And sort of same principle on the arm, leg, buttock, wherever you're evaluating. So we want at least two planes. One view is no views. Next principle is we want to measure whatever's there. So if you're seeing sort of infection or findings consistent with infection, you want to measure the depth of that. Or if you're identifying an abscess, we want to know how big it is across, and measuring in two planes is going to help with that as well. We're going to compare to the normal side. So thankfully for skin soft tissue, oftentimes you have a normal comparator. And if the infection's on the arm or the leg, you can compare it to the exact same spot on the other side, even if your musculoskeletal anatomy is a little hazy for that particular region. And then the last thing that we're going to do, and I'll admit I don't always do this, but putting on color Doppler, especially with abscesses, can help you to rule out a mimic of abscess. And then it can also help you identify hyperemia or increased blood flow around the abscess. So here's a deranged picture of that mnemonic double McDoppler that was generated by AI. And again, two planes, that's the double part. And then the measure is the M, C is compare side to side, and then Doppler is Doppler. So this is what normal skin and soft tissue looks like. This is a pretty deep image. So, oftentimes when you're scanning a skin infection, you're not going to have the depth set quite so deep, but this is just useful for illustrating all the different structures you might encounter. Up top here in the near field, you have epidermis, dermis. Usually that's going to be a bright hyperechoic stripe at the top of the screen. The next thing down is going to be our subcu or our dermis. So our below the dermis, our subcutaneous tissue. Oops. That's generally going to be more hypoechoic, a little bit darker. Generally, that's sort of infiltrated with fat, and fat is going to have a higher water content than some of our denser soft tissues. So that typically is going to appear darker. Next, you might encounter this fascial plane. It's going to separate that fat from muscle. So that's really dense tissue, and it's going to appear brighter because it's reflecting more ultrasound. And then deep to that, you'll see striated muscle. You might see different muscles in the same plane, and you'll see fascia sort of interleaving in between. And then the deepest structure here is bone, and we're even seeing a little bit of either muscle reflected over bone or some artifacts down here. Bone is going to be hyperechoic or bright, and you're not going to see anything deep to it because the periosteum is so dense, it's reflecting all of the ultrasound that hits it. or absorbing it. So you'll see dark shadow deep to bone. So infected tissue or just edematous sometimes is going to look at like this cobblestone path. So you'll have this this cobblestoning appearance when it's progressed to a certain point. And I'll go through there's a little bit finer grades to this, but the cobblestoning is a pretty common appearance for cellulitis. And um, here's kind of a grainy illustration of that right up here. So what happens is below that epidermal and dermal layer in that subcutaneous tissue where all the fat resides, there's a lot of edema and swelling, and that fluid that's gotten into that space is now separating the fat globules in there. And so the fat globules have that sort of cobblestone appearance, and then the fluid going in between, that's the area in between those stones on the cobblestone path. Here's a better image illustrating the same thing. So again, we have like our epidermis, dermis up here, then we get into our subcutaneous tissue, and you can see it's looking edematous. There's fluid. Fluid appears black on ultrasound or dark. So you have that fluid sort of interdigitating with those fat globules. And then another image of that cobblestoning appearance. And again, this is not specific to cellulitis. It just tells you that there's swelling and edema in that area. And then your clinical picture is sort of helping you to put the pieces together. This is what an abscess looks like. So an abscess is going to be a walled off infection. And there's a few things to point out here. One is that it's really discrete. So you have this anechoic structure here. Remember, anechoic or darker, that's going to be fluid filled. And you can tell that it's basically like encapsulated. You know, it's not really there's a discrete cutoff where that tissue ends and the abscess begins. The other thing to note is that as you press down on the abscess, sometimes it swirls. It's called a positive swirl sign. I would not recommend doing that repeatedly on a child with an abscess, but it's another thing that it can make that sort of debris that's filled in there like swirl around or move. There's also a bright signal deep to the abscess. This is called posterior acoustic enhancement. You see this deep to any fluid-filled structure. So it can happen on the backside of the gallbladder, backside of the bladder, and then also in abscesses or fluid-filled structures here. Big blood vessels can do that too. Another abscess. This one, they're really emphasizing that swirl sign. And then this was a very large abscess, and we're not even seeing the margins of it laterally, but you can see where it begins up here in that subcutaneous tissue, and then spreads all the way down here to almost 4 centimeters. There's been a lot of literature looking at using point-of-care ultrasound at the bedside to help make decisions in patients that present with cellulitis or skin soft tissue infection. And the studies generally look at whether using point-of-care ultrasound changes management. So in a patient who they thought had an abscess, did they use ultrasound and then determine that no, that was not going to be amenable to an IND or an aspiration? Or conversely, in a patient they thought just had regular, run-of-the-mill cellulitis, they were just going to treat with antibiotics and send home. They used ultrasound, identify an abscess, and then go for IND or aspiration to try to express pus. And so the studies generally focus on ultrasound's ability to help enhance the provider's clinical judgment in saying there is or is not something that from which we can express pus. These were all pediatric studies. There's quite a few more in the adult literature, but generally it's going to lend quite a bit of credibility to the diagnosis of abscess or to the absence of one. One paper I came across relatively recently that sheds a little bit of doubt on that was this from 2018. And researchers, it was a collection of radiologists and one ED provider. And what they had noticed is that even in patients who had a skin and soft tissue infection who were sent for ultrasound, if the read said there was no drainable fluid collection, which is a relatively common thing for it to say, occasionally they would still find days later that that patient had pus expressed, that the provider had still done either an IND or an aspiration, expressed pus, and it grew something. So they wanted to do a retrospective review at their institution and take a look at how many times that was happening and what were the ultrasound features of that skin and soft tissue infection that would make it more likely to have pus. They confined their search to only buttock infections, so take that as you will, but that's a potential confounder. And they also eliminated they confined it to buttock ultrasounds and only ones where it said that there was no abscess or the abscess was less than 1 centimeter. So they were looking at the association between 11 different ultrasound findings, and I'll cut through all the different ones that they described. But the finding that was most commonly associated with expression of pus, even in the absence of an abscess, was cobblestoning, which was kind of surprising to me because that's always what I was taught was indicative of cellulitis. So cobblestoning was associated with positive cultures with an odds ratio of close to 3 at 8 hours. So 2.8 was the odds ratio. At 48 hours, it was still close to 3. It was about 2.9. So they identified 217 cases. 41 were, just lost my window. 41 were sent for culture. Out of those 217, even though the read said that there was no abscess or drainable fluid collection, and that was within 8 hours, 35 of those 41 grew something. And by 48 hours, 69 samples had been sent, and 61 of the 69 grew something. In every case, in all 61 cases, it was either MRSA or MSSA, and there were 8 negatives. So even if you see imaging that says that there's no drainable fluid collection, if it feels purulent or if it feels indurated and sort of like an abscess on your exam, and there's cobblestoning, then it might be worth going after or trying to aspirate or IND. These were just some of the findings they described and images that accompanied it. So this is a pretty dramatic example of that posterior acoustic enhancement. And this is not quite an abscess. It's not all the way organized. And you might see a report called this phlegmon. Down here, they've put color Doppler on, and you're seeing increased local blood flow. That infection produces inflammation, which makes the tissues release these vasoactive substances, causes that more dramatic appearance of those blood vessels surrounding it. Up here is cobblestoning, and then this is they called it interstitial fluid or tissue disarray, but they recognize that these things exist on a continuum. So in some cases where it's really mild, they would call it interstitial fluid, and otherwise they might call it cobblestoning. This was another look at kids with cellulitis, and the effort here was to try to tie ultrasound findings to how sick they were. What they identified was that kids who had an abscess were more likely to have been sick for longer. They had higher CRPs. That's probably not a surprise to anybody. And if they had symptoms for more than 3 days, they were more likely to have tissue disarray. So the only thing really that maybe adds to our discussion is it's probably, if the kid has had that infection for more than a couple days, it's probably worth looking at just to see if there's anything more organized or collected there. And then most with abscesses had symptoms for at least 4 days. And just some images from their paper. So generally what we're looking for is this continuum. Really early infection, this is comparing normal side over here in the A column to abnormal side on the B. On the normal side, we get this subcutaneous tissue that still looks pretty anechoic. You might see some fascia sort of interdigitating in there. And then on this abnormal side where this early skin infection is happening, you've got brightness in those tissues. So you might have some hyperechoic signal there in that tissue as it begins to become inflamed. The next step generally is that tissue disarray or that cobblestoning appearance where you get edema separating out those fat globules. And if that's allowed to progress far enough, sometimes it forms this abscess where you have this really discrete appearance of an anechoic signal within that subcutaneous tissue. The other things that you can look for, these arrows, I think, are pointing to that posterior acoustic enhancement. And then when you compress that area that you suspect is an abscess, you might identify that swirl sign. So just some cautionary tales, things to be aware of. This was a patient who had some lower extremity pain. Providers got an X-ray. The X-ray demonstrated this lucency up here. It's obviously it's circled in red on the image, but when they looked at it with ultrasound, they identified fluid collection down here close to the bone. So just I'm pointing out this one to say if you have a skin and soft tissue infection, you look at it with POCUS and you're identifying fluid collection or continuation of that abscess all the way down to the periosteum, probably worth considering osteomyelitis, getting advanced imaging like an MRI. So this was a patient that wasn't under consideration for osteo, but began to have kind of unexplainable pain out of proportion to exam. And when they looked closer, they found osteo. This was an example from the adult literature that can happen in kids, certainly. But this was a patient who came in with skin soft tissue infection of the extremity close to the wrist. So you've got cobblestoning appearance up here. And then this was thought to be potentially an abscess. Before they stuck a needle in it or IND'd it, they put color Doppler on and they identified this turbulent blood flow pattern. So you can see a mixture of red and blue flow. So both flow coming towards and away from the probe. And this was a pseudoaneurysm in this patient's radial artery. So especially in patients that get a lot of vascular instrumentation, that's something to be aware of, or kids with vascular disease. Here's an example, first of skin soft tissue, just normal. Down here we got epidermis, dermis, our subq, and then our fascial layers, those bright hyperechoic lines that are going to go across the screen with muscle in between. And then here an example of a really severe complication of a skin soft tissue infection, where you've got subcutaneous air and thickening, and then they're about to show some fascial edema and thickening as well. So this is an example of a necrotizing fasciitis. If you look back on this normal image, look how clean those lines look for the fascial planes. You know, it's hyperechoic. When you're perpendicular to it, it's going to appear really bright, and it's you know, there's no sort of muddying in that tissue. It's pretty clear where those fascial planes are. And then here in our necrotizing fasciitis example, just a lot of edema in there. That line is so chewed up, it's unrecognizable. And then when they scan up to this area where there's subcutaneous air, what we see is this shadowing deep to that air. So air is going to diffract and spread ultrasound. The ultrasound beams hit it, and then very little of that is returning to the probe and providing information. You know, and the amount that is, it's just showing you this bright line. Nothing is getting deep to that. So just like with lung ultrasound, here we end up interpreting artifact. And you've got all this shadowing deep here where you can't see any of that subcutaneous tissue that you were able to see just above or below it. So as we move the probe, you know, and then on exam, you might feel like crackling, crepitus, that kind of thing. So that's what we're looking for with neck fash, is that subcutaneous air, and potentially you'll see that fascial swelling too. And then also, you know, all of your other findings, pain out of proportion, really rapidly progressive, uh, high inflammatory markers. Yeah, so that was it. Just kind of a whirlwind tour. It's not a hard exam to do. It's more so just kind of building up your internal repertoire, recognizing different findings. We're using our vascular probe, linear array. It's the one that's boxed off at the top. That's because we want something that's high frequency, that's going to give us really good resolution, point-to-point differentiation in that image. So you can use like an abdominal probe, in a patient that's obese, or in can't really think of another reason why you would want to do that, but generally the vascular probe or the linear array is going to be your go-to. This typically is going to be able to scan down to about 6 or 8 centimeters. So if the area of concern is any deeper than that, you'll have to switch probes. But this is the one that we're going to go with, and we're just trying to maintain our plane as perpendicular to the thing we're scanning as possible. That's especially important in skin soft tissue. And then there's just a listing of the bibliography.
Do you use this for neck swelling too, to look for drainable collections, or does it get a little trickier?
Scared that something bad's gonna happen.
There's a lot more anatomy in the neck. So I will, and I actually had a patient earlier this year who had wound up having a fourth branchial cleft cyst and had an abscess in their thyroid. But that's not a thing that I wouldn't expect like anybody to just know that that's what they're looking at in the neck. So one other thing that I didn't really go through is sometimes you'll see lymph nodes that look like abscesses, and it's just a little bit more nuanced, and you need a little bit more experience, I think, to recognize those. But that is a pretty common concern. Obviously, in kids, you end up with a lot of neck swelling that's unilateral, and then you end up sort of hemming and hawing about whether it's a necrotic lymph node or is it an abscess, and then somebody has to go in and drain it or remove it, or you're going to treat them with antibiotics for an eternity.
Hey Scott, it's Nina. Thank you so much. This was a great overview and lecture. Quick question. I don't know if you or anyone else has any experience of scanning over recent surgical sites or incisions. I've always been too nervous to kind of use point of care ultrasound in that setting, looking for any sort of skin soft tissue infection. And I just was wondering if you guys had any experience in that.
I do not. I usually would avoid that and just kind of use more clinical judgment and lean on the surgeons for sort of their discretion at whether or not the surgical site is infected. I don't think it would. I don't think you're going to cause any harm as long as you're at least like 24 to 48 hours out. So at that point, I believe that incision is reepithelialized. You're obviously not like you're generally not using sterile ultrasound gel, so I'm not putting definitely not putting ultrasound gel like on an open incision or something that's still healing.
Yeah, I think I'm more thinking like kids who come back 2 weeks later, like that kind of a.
Yeah,
Yeah, I was just
yeah,
curious.
for sure. I would definitely look if that were the case. Uh, I think I can't think of like a particular case where that's happened, but yeah, I think that it would probably be pretty helpful in trying to sort of elucidate maybe a like a stitch abscess or something that's like discrete underneath that infection or that area of redness.
I would add something to look for as we talk about in ultrasound things you have to worry about would be post-op seromas in some of our patients. We actually had one this week in a post-op appy who got admitted for concern for cellulitis, got imaging, and it was actually more consistent with the seroma. And I think I presented on one maybe a year ago, Nina, it might be recorded, about a kid who had a concern for a septic joint, got aspirated, and they caused a seroma afterwards. And so those tend to be more uniform, but they do look like a pocket of fluid and can very much look like an abscess. And that's just something to think about when you're looking at some of these surgical sites or post-op kits, if you do go looking.
Yeah, good word for sure.
lot of times the seromas too don't have a lot of the cobblestoning around them. And they don't have like the nastiness inside. They're much more of a uniform fluid collection, almost cystic in nature. So that's another thing that can kind of help you. But like if a kid that's 2 weeks post-op that comes back fever and has an angry incision, I would definitely do that. If you're nervous about it, you can use sterile gel. You know, a lot of places will have the little packets of gel that use for like finger lube if you're going to do rectals or something like that. That's all sterile. So you can put that on there. You can also put a Tetraderm on to make it somewhat sterile. It's more aseptic than anything.
Yeah, and if you can get your hands on a probe cover too, so the probe cover kit is going to have sterile gel inside of it. So if that was something that you wanted to look at. And you brought up a good point too about the that surrounding area. So you think about the abscesses being sort of the eye of the storm, and then there's still like hurricane around it, right? So if for an abscess, you're going to have that discrete area in the middle, but you're still going to have evidence of skin soft tissue infection around it. So that cobblestoning appearance and that tissue disarray. Whereas with like a cyst or something, typically it's more isolated. You know, you're going to see that anechoic signal, but the surrounding tissue looks relatively normal. Cool. If there's no other questions, we can shut it down. And next month it would be a case presentation month. So if you have images that you want to share that we can go through, we'll do that for sure, and people can comment on it. And then I'll reach out to a couple folks about sharing some images just so we have something for sure. And that'll probably be a pretty quick one as well. But yeah, that was kind of our thought moving forward, was that we would sort of alternate back and forth with just kind of cases, and then try to go through a pretty common application that a lot of people in the survey had indicated they were interested in. I'll send out a message at some point, probably next week, with the link to the recording. But thanks, guys. See you around.
Thanks so much.
Thanks, Scott.
Awesome. Good to see everybody.